So we have Jon presenting today for our current topics in science class, and he's going to talk about a tour of anesthesia stories, science, and the desperate need to make surgery better. And if you just logged on, you have not missed anything. We were just pre-chatting because we were so excited to talk. So I'm going to pass it off to Jon.
It's so nice to see like other humans in the era of COVID. You're like, oh, look, other real people. It's very interesting. Well, hey, y'all, my name is Jon Lowrance, and Clemency and I, we teach for the same organization, National Outdoor Leadership School. I see she's got her little flag on there. I've got my water bottle with my Knoll sticker. What's up? So so we both teach for Knowles Wilderness Medicine. I'm going to tell you a little bit about my story as I get going, so you can kind of see, who I am and what I'm about. But in short, you see a bunch of info on the screen here. I'm down in Portland, Maine. I'm on the coast in Maine. I was just up in East Burke, kind of doing a van tour with my wife. She's a CRNA just like I am. And let me see. Hey, Clemencia or Emily, give me like a 5-minute warning when it's like 4:45. I don't think that I have a clock anywhere in here. I don't see one on my screen, and that is super dangerous because I will talk for a long time. But anyway, I'm a CRNA. I work in anesthesia. I'm going to tell you all about what that is and what that means. You see the clinical coordinator on there. So I don't work directly with the university, but I manage all of our graduate students who are doing their anesthesia training. When they come to the hospital, I am their clinical coordinator. So I manage them in the clinical environment as they're training in anesthesia. And I'm going to tell you about that path and what that looks like. So I'm so stoked for this opportunity to present to you all. And I really appreciate Clemencia reaching out to me. This is incredibly dangerous. She has no idea what I'm going to talk about. And so hopefully it meets your all's needs, and we're going to keep it fun and interesting with pictures and stories and all that kind of stuff. So let me get on to the presentation. So I'm going to give you a little bit of a behind the scenes tour of the world of anesthesia. I'm going to talk to you about the path to becoming a CRNA or a nurse anesthesiologist. We're going to look at some of the science that's shaping our current practice in healthcare. And then hopefully I'm going to lay out a case for all of you. So other scientists, activists, social reformers, and creators, which are all of you have incredible potential to shape not only your future, but the future of healthcare, the future of science, through what you're doing. This may seem like a super boring, path through undergraduate school. There may be stuff that doesn't light your fire, but I want you to know that even though it might seem like you're jumping through hoops at times, you have an incredible potential to shape the way the world looks in the future. And so we'll talk a little bit about that. So come on, RBG. This is me in Portland, Maine, chilling with RBG when it was showing the documentary a couple years ago. And what a sad time in our nation to lose such an amazing human being. If you don't know the story of Ruth Bader Ginsburg, she's definitely somebody, hop on YouTube, watch a story, talk about, I love the tagline here, hero, icon, dissenter. Someone who was so steeped in the science of what she did as a law professor to then go on and really, shape the nation in terms of equal rights for women and just equalizing the playing field from an economic and a social justice standpoint. So we've lost a giant this year, and our world is in a crazy place right now. But anyway, got to give a little shout out to RBG. So what path did I take? I came from Missouri, hometown of Rush Limbaugh, of all places, Cape Girardeau. And that's where I got my Bachelor's of Science in Recreation. So my undergrad was actually all about playing outside. I got a certificate in outdoor leadership. I became an outdoor guide. I started teaching wilderness emergency medicine. I was leading backpacking trips, canoeing trips, teaching swiftwater rescue. And I started teaching wilderness emergency medicine for other outdoor guides. And it was there that I kind of caught the stoke for healthcare. That ended up me taking a path to becoming an emergency medical technician, working on an ambulance, and then back to nursing school for a bachelor's in nursing in St. Louis. and then on to a Master of Science in Nursing Anesthesia. I currently work at Maine Medical Center in Portland, Maine, and that's a little picture of our hospital. Here's some other organizations that I work with. So Landmark Learning, Knowles Wilderness Medicine Institute. This is us. This is me. This is how painful teaching for Knowles is. This picture here, teaching along the beach at the ocean here in Portland, Maine, teaching a 9-day Woofra course a couple years ago in May. What a beautiful place. We're watching the sailboats go by. Rocking out on a Leave No Trace Master Educator course down there in Ecuador. Teaching international climbing guides about environmental ethics and how to take care of their federal lands and their public lands from a non-recreational or non-motorized recreational standpoint. So a lot of interesting stories back in the day. And then currently I teach for Cornerstone Anesthesia conferences. All healthcare providers have to have continuing education credits. And that's kind of an outlet for me to be able to teach other CRNAs. And then I run a podcast actually called Anesthesia Guidebook. So this is an educational podcast for other anesthesia providers. And today is International Podcast Day. So, whatever your favorite podcast is, be sure to sneak in an episode this evening or tag over and check out Anesthesia Guidebook. I'm going to show you a couple of slides that link to some shows I put out recently. The last one I did is with a girl out of South Carolina named Kiki, who we sit down and talk about kind of the path to becoming a CRNA. And then this is a photo of me doing advanced airway training on a pig trachea, actually, during our graduate school. So these were humanely, this is pigs that went to slaughter for meat, I guess. We're recycling their bits and pieces to do training on. So this is talking about front of the neck access. Turns out pig tracheas are really similar to human tracheas. And so you can see we've got a little airway device there that we would use in an emergency to help people breathe if they couldn't breathe through their mouth and nose. Here's some other photos. I've got my 2 dogs that were on our van trip with us. That's Toby and Tucker in the upper right corner there, upper left, I guess. And then my wife, who's a CRNA, teaching and canoeing and paddling are some other passions of mine. So, so we'll talk a little bit more about, specifically anesthesia and my role in teaching there. But here in the bottom corner, in the bottom of the page, you can see some anesthesia students training on a high fidelity simulation lab. So if that mannequin looks like he's kind of plasticky looking, it's because he is plastic. So they're doing high fidelity simulation, which we'll talk about here in a little bit. So this is what my office looks like typically. This is just after a case, so there's no blood on the floor or anything like that. But this is one of the operating rooms at our level 1 trauma center here at Maine Medical Center. And you're looking kind of from the foot of the operating room bed, the OR bed, back up towards the anesthesia workstation. And so I'm going to talk to you about some of the gear that we use and kind of the outline of what stuff looks like. So kind of zooming in a little bit closer to what my office looks like. We have a chair, which is pretty sweet to work in an operating room, but get to sit down. It's kind of nice. I mean, we're all about relaxing, You got to train hard to become a CRNA, but then we're all about chilling once you get there. And so what you see here, you see this machine over here that's got a computer screen on it and a monitor up at the top. That's the anesthesia machine. The yellow dial there and the purple dial there, those are inhalational anesthesia medications. So you can see some plastic tubing is the breathing circuit. There's a little green mask and a green bag there. And then there's a yellow pillow there where people lay their head down. So we hook up monitors to people. We keep a close look at their heart rate, blood pressure, oxygen saturation, that kind of stuff. The anesthesia machine helps us keep patients asleep during surgery. It also helps us monitor their vital signs. It helps us breathe for them. We chart data on a record that goes to billing that has to do with economics and quality control and that kind of stuff. The blue cart is a toolbox of difficult airway tools. And then this kind of gray-brown cart is a small pharmacy, actually. So anesthesia providers are trained to give all different kinds of medications. We're like our own pharmacist in the operating room. We pull out medications that we want to give our patients and we give them directly to the patients. So we work with a really high degree of autonomy to take care of patients in the operating room and to get them through the OR safely. Here's some tools of our trade. So the little metal device there is a laryngoscope. So that helps us look at people's larynx. So doing the laryngoscopy with a laryngoscope. And we've got some breathing devices there, some forceps to help us move breathing tubes in and out of the airway. This setup is actually set up for putting a breathing tube in the nose of a patient, so a nasal intubation. And then you can see a few of the medications that we use to get people off to sleep and to keep them pain-free and that kind of stuff. So you probably have heard of like fentanyl as, in terms of like a medication that's abused on the street in terms of the opioid crisis. We give that stuff every day. It's a really safe medication to give in the operating room as long as you have proper training to do it. Same thing with propofol. A lot of people are familiar with that as like the Michael Jackson drug. That's what his family physician was giving when he gave too much and he didn't wake up from the general anesthesia that he was being given. So these medications can be very dangerous, but if you train in to figure out how to give them safely, they can be on point in terms of keeping people safe and comfortable for the operating room. So this is what a crowded OR looks like during a typical anesthesia case or surgical case. What you got going on here, you got Michelle, my good buddy Michelle. She's a graduate student right now. So she has completed her undergraduate training in nursing, and then she got ICU experience as a critical care nurse. And then now she's doing her master's degree in anesthesia. So I was serving as her preceptor or clinical trainer this day. And she's in the OR. She's managing this stack of IV pumps with all of these medications on an IV pole. And what this surgery is, this patient was like a middle 50s-year-old woman who had a cancer in the bone of her jaw. So she had this invasive cancer that was eating up the bone in her jaw. And you say, well, why aren't you doing surgery on her jaw? That looks like her leg. It is her leg. There's actually 2 surgical teams in the room right now. So you see these 3 men who are gathered around her leg. What they're doing, they have the leg prepped out. They're actually going to cut out part of her fibula. So they're going to take a bone and muscle out of her leg, and they're going to bring that up and cut out all the cancer out of her jaw, and then put her leg bone in her face, and then sew everything back up so that she's cancer-free and she still has a jaw. So it's a very complicated surgery. This surgery lasted about 10 hours and was very difficult to manage in terms of the physiology of this patient, keeping their fluid balance correct, their electrolytes normalized, their temperature regulated, their ventilation status regulated, and for her to wake up pain-free and breathing okay at the end of the procedure. So you see the 3 surgeons around her leg, and then in the green cap, kind of holding a sharp pointy thing, that's our airway surgeon who is going to be working on her neck. And I see we've got a couple of comments, so I got to pull this comment box out here and check some of those out. I'm going to move my screen around a little bit. Since you teach about anesthesia, is there information you're holding back from this presentation that you have to take the class to learn? So Xavier. So I'm going to tell you about the path to becoming an anesthesia provider here in just a minute. We'll talk about that. How often do people wake up in the operating room? They only wake up when we want them to wake up is the right answer. So there are popular movies in Hollywood about awareness under anesthesia. It's only if someone makes a mistake that someone wakes up when they're not supposed to. And honestly speaking, in today's world and practice of anesthesia, it's really, really rare. Like as rare probably as like an airplane crashing or something like that. Like it's super rare. There are moments during surgery that we intentionally wake people up, but we wake them up in a way that they are completely pain-free. We do some really invasive surgeries with patients completely awake because we want them to be awake. In fact, some of the brain surgeries that we do, we keep people completely awake. As the brain surgeon goes in, they're actually manipulating and taking out tumor, and they want to see, is the part of the brain that they're removing actually affecting people's speech and cognition and ability to function. Sometimes we put in deep brain stimulators to help with Parkinson's disorder, to take away tremor. So these are electrical cables, like a pacemaker, but for the brain. They go in and they'll actually put those cables in, and they'll have people repeat things like, today is a very good day. Today is a very good day. Today is a very good day. and you'll see them actually kind of turn the brain off, and they're dialing in the electrical energy. So it'll be like, today is a very good day. And then they'll turn the brain back on. Super wild, sciencey stuff. And we're there with them, keeping them comfortable during that whole time. All right, so some other questions. What are some of the things that might mess with the anesthetics and stop them from working properly? That's a great question. Disconnects from our anesthesia machine, disconnects from our IVs. So we monitor our physical environment really carefully to make sure what we're giving the patients to keep them asleep is still getting to the patients. Let's see, is there any consultation between the anesthesiologist or doctors before giving medication? I'm going to talk exactly about that here in a minute. I'm going to outline what that looks like and the level of autonomy for CRNAs. How much does typical cancer surgery cost? That's an incredible question. It all depends on the type of cancer, the surgery, your insurance. I'm going to talk about economics as we go along. Anesthesia is determined really by physiology and pharmacology, and really importantly, the patient's weight. So every IV medication is given weight-based dosages. So little bitty tiny, like 6-hour-old babies that go for surgery, they weigh like really, they don't weigh a lot. Like, 4 pounds, 2 pounds, they get, everything's dialed up in like 1 cc syringes. Really big, morbidly obese, like 4 or 5. We had a 600-pound patient recently having gastric bypass surgery to help them deal with their obesity disease. Those patients get a lot more medication. Rachel says, my mom woke up while in surgery, which is why I asked. It all depends on what your mom's case was, Rachel, in terms of, how that went down. I would be happy to talk with you maybe specifically by email. We can talk through that a little bit more if you got specific questions. How long is the anesthesia process? Does it depend on totally depends on the surgery. They're not supposed to eat or drink. What happens if they do? Can it become fatal? I'm just going to read a bunch of these and maybe I'll answer all of them. Okay, cool. Okay, cool. Yeah, these are great questions. Y'all are like super, I don't know if you get points for like giving questions, but you're super engaged. Thank you so much for your questions. That's awesome. So eating and drinking before anesthesia, that's all about protecting someone's airway. If you eat a big meal and then we put you to sleep, you lose control of your esophageal sphincter, the thing that keeps the food in your stomach. So that food would go up your esophagus and then you would aspirate that into your lungs. So I'm going to talk to you about enhanced recovery after surgery here in just a few minutes. I'm going to blast through some info. I told Clemencia and Emily before we got started, this is kind of like a shotgun shot of information. I've got a lot of info and slides and pictures. I'm going to kind of give you, I see it's 4:20 right now. So I'm going to shoot through a bunch of info real quick, and then we'll really open this up because I know you probably have a lot of burning questions. So the information about NPO status is about keeping you safe, but I am going to show you some information on enhanced recovery after surgery, where we're actually intentionally having people drink a complex carbohydrate beverage up to 2 hours prior to surgery. Emily will love this as a registered dietitian because it keeps people their glycemic control at a normal level to where we're not starving them ahead of surgery, and it helps them weather the stress of surgery from an immune response standpoint much better than keeping people starved or hungry upwards, for 12 hours or more. So I want to talk to you about all that training in college and all that kind of stuff. So let's get back to the slides. You're going to see some of that info. So super cool surgery. We do a lot of fascinating things. This is my friend Vaunette. She's at the head of the bed. She's breathing for someone. The photographer kept the patient out of the picture for privacy standpoint, but we often breathe for people through this mask, manually breathing for them, giving them breaths through the bag from the anesthesia machine. So in the United States, anesthesia is performed by teams of CRNAs, physician anesthesiologists, and anesthesiologist assistants, or CRNAs or physician anesthesiologists working independently. So it depends on the care team model. The bigger hospital you work in, the more common it is for these groups of people to work in teams because it enhances efficiency and throughput, which has to do with the economics and also just the efficiency of, like, you can treat more patients if someone on the anesthesia team is kind of queuing someone up for surgery while someone is in the OR taking care of them and someone else is looking over them afterwards. So you work in a care team model to kind of get people through the operating room. Here's an example of that care team model. So the woman in the glasses is a physician anesthesiologist at Maine Medical Center. The man in the blue mask is a CRNA. And then the woman in a mask without glasses, she's an operating room nurse. And they're putting this patient to sleep. Likely her arm was splinted in the emergency room, and now they're putting her to sleep to then go in and surgically repair a broken arm. Here's an example of CRNAs working independently. So 100% autonomy from physician anesthesiologist. This is my friend Dustin Degman. He, in one of the podcasts I used to produce is called From the Head of the Bed. So I did a 3-part series with him on combat trauma anesthesia when he worked during the Afghanistan war back in 2012. So you can hear a little bit about him, and you can see he's in a much more relaxed kind of, he's not in scrubs, he's in his military fatigues. This is in Afghanistan in a temporary hospital. You can see it's obviously made out of plywood and kind of skeletal makeup there as they're, kind of a physical space, skeletal, taking care of patients that were wounded in the battlefield. So what do? We do magic with science so that you stay alive during surgery, right? More specifically, anesthesia providers keep you alive during surgery, monitoring every breath and every heartbeat, and make sure that you wake up as pain-free as possible. We manage your entire physiology. So your sedation, your analgesia, which is your pain control, your physical response to surgery, your fluid status, acid-base balance, blood volume, temperature, your physical position of your body, your safety, all of that while the surgical team fixes your problem. And that could be as simple as whether that's pulling a tooth or literally taking out your heart and putting a new heart in during a transplant. Real quick, I see that the longest surgery I've ever been a part of, like 16 to 18 hours, microvascular flap case for breast cancer, where during the same surgery, they do a double mastectomy, and then they'll take a fat graft out of the belly and reconstruct the breast for women immediately. So the cancer's removed, and they're immediately reconstructing the shape of the breast with fat removed elsewhere. It's a lot of microvascular surgery, reconnecting all of those really small, tiny blood vessels so that these grafts continue to work. So those are cases that all of our cases start about 7:30 in the morning. And sometimes those cases don't end until like 1 o'clock in the morning the next morning if they're having trouble with their flaps. So sometimes cases can go really, really long. Okay, so what else do CRNAs do? We collaborate with other CRNAs, physician anesthesiologists, surgeons, dentists, podiatrists, gastroenterologists, all of these other providers to provide sedation, pain management, general anesthesia, resuscitation, airway management, and critical care. I'm going to start kind of flying through some slides so you can see some of the shotgun chatter that I've got for you, and then we'll take some more questions. So this is what all Maine CRNAs look like. We ride lobsters in our spare time. So just in case you were wondering. Committee's like, what? And then a little bit more about the path to becoming a CRNA. So you have to have a bachelor's of science in nursing, critical care nursing experience, usually 1 to 3 years as a registered nurse, then a master's of science in nursing. And in January 2022, that's going to become a doctorate of nursing practice. There is a podcast I just put out with Kiki Mattress down in South Carolina. She runs a blog and a Twitter feed called the CRNA Chase. So if you want to hear more about the path to becoming a CRNA, you can hear about that. What's really interesting is that Kiki is a Black woman in America with 3 kids, and we talk about the systemic racism in healthcare and in higher education, and how she faced those challenges as a Black woman who was working through her anesthesia training while she had 3 kids to pursue her dream of becoming a CRNA. She started out with a technical college degree in engineering, and then became a surgical technologist, and didn't believe that becoming a registered nurse and a CRNA was in the cards for her. She thought the path would be too challenging. And she found a mentor in the operating room who was a CRNA who coached her towards that path. And we unpack her story in this podcast. It's a really powerful story. I would totally encourage you to check it out. Even if you have no interest in like becoming a healthcare provider, it's just a powerful story about pursuing your dreams. So I think you'll enjoy that. So What's up with COVID-19? As you all know, this has dramatically changed our world this year. As healthcare providers, we're definitely dealing with this. I don't have a lot of facts and data to share with you. I would definitely steer you towards programs like the CDC, the World Health Organization, for facts about COVID-19. I do want to turn you on to this guy, MJ Hibbelin. He's a graphic artist who writes in a comic book style. He put out a book called Frontline Heroes. His work is available on Instagram as well. And this is probably the most iconic picture that he drew of kind of the human response from healthcare providers to COVID-19, really personified this unseen virus as this vicious monster, and healthcare providers as a defiant workforce who have been pushing back against this worldwide pandemic. He cast them in kind of a superhero light, which is really fascinating. I think it's been very empowering to see his work as a healthcare provider who's dealing with coronavirus on the front lines and the inherent risk that brings from doing airway management. I mean, we know this is a respiratory disease that's passed through particulates that people breathe in and out, and then CRNAs have to go in and put breathing tubes in people's airways to make sure that they're safe during this time. So it's been a really interesting time in healthcare. And then I sat down and I did a podcast with the artist. He's a guy in England. He's got a lovely British accent if you want to hear a little bit more about him. So again, just a little bit of a tour of some of the things that we're thinking about as healthcare providers and anesthesia providers right now. There's been a trend towards opioid-free anesthesia in the United States. So I'm just going to check the time here. So we got about, 15, 20 minutes or so more of me spewing information at you. And then I'll focus 100% of my attention on answering your questions. So as you know, as you've probably heard about, there's an opioid crisis in the United States. And healthcare providers are kind of involved in that being a problem. Really big pharma was a huge instigator to that issue in making opioids super accessible, overproducing opioids in the 90s, and then pitching them to healthcare providers as this is going to be a completely revolutionary pharmacotherapeutic, a medication that is potential therapy for patients that are in pain. So perioperative pain, chronic pain, opioids were pitched as the panacea, the silver bullet. And then we realized that they have this incredible addictive power. We realized that they have these incredibly harsh side effects, mainly from kind of a public health perspective, the addictive power of opioids. So in anesthesia, in a perioperative environment, as I mentioned earlier, we use opioids like fentanyl, morphine, hydromorphone, remifentanil, sufentanil. There's all kinds of opioids that we use to manage people's pain in a very safe way and in dosages for timelines that are not addictive. It is. I want to be really clear about this. If you go for surgery, it is completely safe to get opioids from healthcare providers in a hospital, in a perioperative environment, in a way that will not put you at risk for addiction. So please, if you or your family members are having surgery, don't freak out because of this talk, because, Jon, said you're not supposed to have opioids. They are safe in a short-term time frame. But in that short-term time frame, they still have some really negative side effects like nausea, vomiting. They make your belly slow down, peristalsis, and normal bowel function is altered. There's respiratory depression from opioids. So one of the trends in healthcare has been to swing away from opioid-free anesthesia. So folks like my buddy Tom Baribeau, who's a CRNA, created the Society for Opioid-Free Anesthesia. So they're putting out clinical tools and references to help anesthesia providers who traditionally have used opioids as kind of a go-to tool to take care of patients perioperatively, to get away from those medications and to use non-opioid medications to get people safely through surgery in a way that has better outcomes and for them to still be pain-free. So we do have lots of alternatives to opioids. So this has been a trend in healthcare. So here's an example of that. And I'm kind of dipping into this idea of enhanced recovery after surgery with the American Society of Enhanced Recovery. So this is kind of a complicated graph that shows you from pre-op all the way through post-op and all of these different layers of different kinds of medications. And if you read through this list really specifically, other than SAB, which is a spinal anesthesia block, which is a little dose of medication that goes in your back through a needle injection around your spinal cord, it says opioid there, but nowhere else in this slide are you going to see opioids as a foundational tool for managing people's pain perioperatively. So we're training right now, and we're kind of retooling and reshaping the way anesthesia providers think about taking care of patients perioperatively, getting them away from relying on opioids to give patients better outcomes. So, and that's one way that anesthesia providers are helping kind of answer this national health crisis from a public health standpoint in terms of the opioid crisis that we have in America. So this is kind of an outline of all of the different phases of enhanced recovery after surgery. This is another way of like kind of a new way of thinking about how people go through surgery. So what I want you to take away from this is that as a healthcare provider, we're not just focused on like the day that you have surgery and making sure you have a good experience. You having a good experience having any kind of a surgical procedure is really a comprehensive plan. Ideally, and this is pivotal when you think about healthcare and the change I kind of want to challenge you with towards the end of this presentation, when you think about how can we reshape surgery, how can we think about healthcare in a more functional way, you know, in the United States, we're really, really tech heavy, and I'm on the sharp end of that as an anesthesia provider, right? I showed you my office. It's filled with gizmos and monitors and fancy tools and nifty, you know, surgical techniques. We do really tech heavy, you know, pharmacology heavy, science heavy information like interventions. But the real power in healthcare is what we talk about like, in terms of thinking upstream. If you can prevent a patient from having a need for surgery, it's so much more powerful to think about preventative medicine than it is in acute care medicine. So stuff like what Emily's doing as a registered dietitian, from a global standpoint, things like what Knowles does and getting people outside and active and moving can be so much more powerful from a public health standpoint than just throwing a lot of like technology at the disease states that we have because we haven't been taking care of our bodies. But anyway, if you do have to have that acute surgical intervention, we are still thinking about that from a comprehensive standpoint. All right. So cruising in on the closing minutes of what I want to tell you, and I've got so many more slides. So I want to shift gears a little bit and talk about like the science of healthcare and how we think from a system standpoint and also individuals. So we know, this is shocking, that it takes on average 17 years for new information, like new science that's been discovered and verified, for that information to be adopted in a widespread way in actual clinical practice. There's a lag time from new science until that's actually adopted in practice. And that blows my mind. And as an educator, that's something that I want you to chip away at through mediums like podcasts, where you can get the news out quicker that, hey, there's a new way to think about things like enhanced recovery after surgery or opioid-free anesthesia. So this graph is about instigating change, and this can be applied to any kind of field. We know that there's innovators out there who are pushing the boundaries of science and change in whatever domain that you're interested in working in. So there's folks like Tom Baribeau who are creating the Society for Opioid-Free Anesthesia. There's early adopters who catch the story early on and say, this, I want to embrace this change. I see the value. I'm on board. Let's go for it. And then there's a chasm until you get the rest of the crowd to buy into this. People want to see the data. They want to know that this is an acceptable change, that, you know, national societies are getting on board with this, that healthcare is really moving in a new direction. And then once that early majority comes on board, then it's more likely that a late majority will follow along. And then of course, we're always in any kind of change or innovation, there's always going to be a bell curve. There's always going to be laggards who drag their feet, who drag their heels and say, I'm not changing. I don't believe this. I don't want to change. It's too uncomfortable. And we want to find ways to bring those people along as well. I'm going to skip over this. It's just kind of a a systems way to look at integrating ERAS into healthcare. I'm pretty stoked about thinking about how to become a catalyst for change, being that initial spark to get other people to motivate. And so I want to talk briefly about, how do we make decisions? I would challenge you to think about, as an undergrad at Northern Vermont University, how do you make decisions? How are you making decisions about the world around you? Whether that's politics, economics, the path you're going to take, what kind of food you're going to eat, or, where you're going to go out for dinner or whatever. So, do you think, like whatever you think is best, right? Like whatever your opinion is that like a reasonable way to make decisions? It kind of depends on the decision you're making, right? What your political party thinks. Obviously, like I'm not going to wade into politics, but we see this, we feel this right now in an election year in the United States. You can see this with how people are responding to the science of COVID-19. There's really good data, but just the idea of science is being questioned in our political party process. I had, and in science and facts and evidence, I had this really interesting interaction the other day at the hospital where a cardiologist was telling a patient who had a heart attack, hey, we're going to put you on a blood thinner and we're going to transition you from one blood thinner to this other blood thinner. And I'm just like, he's just letting this patient know that they're going to make a change in his medication. And the patient was like, said something like, yeah, like, y'all do whatever you want to anyway. And the cardiologist responded with like, no, it's like actually science. Like we're not just making a change in your medication because I want to, or it's my opinion, or it's what I think it like, we're doing this because there's data, like there's facts. That's why we're changing your medication. And I just thought it struck me as so interesting in 2020 that like, that science is still valid, right? Like obviously, but that's his cardiologist's answer to the patient is like, no, like science is real and there's facts and there's evidence and that's how we make decisions. And so that's what I want to tell you is that in healthcare, that's how we make decisions, right? And so there's this quality of evidence from, if you look down at the bottom, you've got things like opinions. And again, it's not just like John's opinion, or Emily's opinion as an RD. It's not just like, well, this is kind of how we feel about it, but this is even expert opinion, right? People who have studied this, people who have gone to school. And then there's case reports, case series, and cohort studies. Well, like when we do this, we've seen that this happens in this group of patients. So maybe this is kind of an interesting change. And then you get into like randomized control trials where you're really testing things, and then systematic reviews of lots of randomized control trials where you're trying to test things and see how can we compare evidence, and then doing a meta-analysis of all of this. So I just want to let you know that there's layers upon quality of evidence, and in healthcare we're really looking for those like systematic randomized control trials, reviews, meta-analysis. We don't just do things in healthcare because it feels good or it's a new trend or it's something that we saw. We're really looking for actual data to shape our decision-making and behavior. This is going to be an example of that. The Cochrane database is a database of systematic reviews. And I'm just going to skip over this slide for the sake of time. And I want to talk to you briefly about systems thinking. I want to just introduce these ideas and concepts, and then we'll kind of wind down towards your specific questions. So systems thinking, quality analysis, economics, human factors, decision-making, and expertise. So systems thinking is really about designing processes that result in better outcomes, and not just like individual human performance, but if we build a system that this is the way that we all do this thing in a particular way, are we going to find better outcomes than if John just goes in and does whatever he wants to get someone through the OR? What has better outcomes? And so, spoiler alert, like systems thinking often does, but what I think is really fascinating about healthcare is that even though we design these really eloquent systems like enhanced recovery after surgery that has this really complicated like network of best practices around how to care for people, including opioid-free anesthesia and all these interesting concepts, we as healthcare providers are still humans that enter the arena of the operating room. And, if we have a good day or if we have a bad day, that shapes what we do. And we're still like fallible people. So our human performance and our own individual expertise still really matters on the outcomes that we give our patients. And I think it's completely fascinating. And I devote a lot of my time as an educator and a scientist and a thinker and a creator and a podcast producer to this idea of like, how do we think about systems? How do we think about human factors? We look at things like closed claims analysis. So we look at all of the cases that have gone to litigation. So a claim is like when someone submits a claim to their health insurance. So there was a problem. So now there's a claim that health insurance is going to pay out. Well, then there's scientists that sit around and go, well, what are people submitting claims about? What are the problems that have happened? And if we analyze the problems, can we find better solutions to those problems? So this is a study on massive hemorrhage, looking at why do people bleed in the hospital? So trauma cases, surgical cases, cases where you expect people to bleed, cases where you don't expect them to have a lot of blood loss. I won't get into the data. It's super fascinating. We can talk more later if you want to know about it. I love talking about this stuff. I've got a 2-hour talk just on massive hemorrhage and how to manage it for science, for healthcare providers. So I'm just going to skip through this for sake of time. So this is looking at some of the specific closed claim data. Interestingly, is what I was getting at just a minute ago, a breakdown in team communication was noted in 60% of claims. So when people are bleeding in an OR, it's a super stressful environment when someone's hemorrhaging and you don't know why. And when someone has a bad outcome in that moment, 60% of the time, it's been shown that communication between the anesthesia provider and the surgeon or the nurse or the tech or the surgical technologist or the blood bank, there's a breakdown in communication somewhere, and that contributed to the patient having a bad outcome. So, and this is a breakdown of the data. We'll just skip through this. So there's substantial room to improve both systems of care and individual and team performance. This is just some other studies that show about, studying anesthesia providers in simulated environments and showing that we have a lot of room for improvement. Interestingly, the simple task of using a checklist has been shown to improve outcomes. So we utilize these checklists in the operating room, specifically when there are emergencies that go down, so people have a better performance during those really stressful moments. So we have like manuals, all of these manuals, 1 through 25. There's 25 different types of emergencies that this manual covers. Here's one we were just talking about, intraoperative hemorrhage. So you flip that open. It's actually got that book right there. So, crisis manuals that you can flip through that help guide decision-making and thinking in the operating room. Inside humor. This is really powerful, right? As undergraduate students, this is a tweet from somebody, but it says, student, you don't study to pass the test. You study to prepare for the day when you are the only thing between a patient and the grave. And as an anesthesia provider, this is a really powerful statement for me. And it's part of the stoke that I have in what I do is that, 98% of the time, what we do are routine surgeries, like, literally pulling teeth or fixing a broken bone or something. But there are times where our patients' lives really hang in the balance. And what our team does in that moment, how we act, how we perform, how we communicate, how we think can really influence the outcome that patient has. And so I just want to encourage you with that. Like, even during your undergraduate studies, you could be pursuing a liberal arts kind of undergraduate plan, but the way you develop your study habits, the way you think about what you do. And I'm not saying this is just for healthcare providers, but you might be an innovator. You might go on into pharmaceuticals. You might go into systems thinking. You might go into human performance. You might go into education. You might go into designing a new way for people to use digital media to create educational outcomes or pathways for people. Whatever it is that you do, thank you so much, Clemencia 450. We're wrapping this up. You can have a profound impact. And this really encapsulates that for me. So here we go. This is a Zoom meeting. So here we go. Zoom, developing CRNAs. Oh, Noel's pictures. What? thrown in for Clemencia. All of that background in Knowles Wilderness Medicine has helped shape what I do in the operating room now. I'm a super nerd on the concept of developing expertise. Again, human performance and outcomes. Knowles, we talk about judgment and decision-making. I had a whole section on that for you on there. Skills, the skills, knowledge, and attitude. All of these concepts shape what we do as scientists and healthcare providers. There's stuff in here about Maslow's hierarchy of needs, the flow concept. You probably have gone over that with Mihaly Csikszentmihalyi in your courses. Super interesting. Carol Dweck's growth mindset, Angela Duckworth, grit. Come on, this stuff is amazing. Deliberate practice with Anders Ericsson. I could talk all day about that. Briefly, remember, anesthesia school is super easy. It's like riding a bike, and the bike is on fire, and the ground is on fire, and everything is on fire because you're in hell. Graduate school can be super difficult. Come on, my people in East Burke, transition full suspension mountain bike. What? All right. Stress inoculation training, how to actually get better at stressful events. There's info in here. I can share these slides with you if you want to read through it later on. Blah, 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 blah. Super interesting stuff on here about, I was going to talk to you about, more evolving science and stuff about vape pens. If you vape, you should totally stop. It's not a vapor. It's superheated vegetable oil that will totally ruin your lungs. It's a horrendous thing. Vaping is so not better than cigarettes. Pharmacology. Check this out. Boom, the molecular shape of Sugammadex, one of the biggest pharmacological changes in healthcare and anesthesia in the last 10 years, looks just like a daisy. Isn't that cool? Science is beautiful. And here's my wife and I, and now I'm going to give you my full attention to answering questions. So Clemencia and Emily have offered to field questions. I've not read anything for the last 20 minutes, so if you guys want to jump in with some themes or really big stuff, we'll take your questions for the next few minutes.
Okay, it will take me a second to go up in the chat. Okay, I think this is about where you left off. What is the difference between a CRNA and a physician's anesthesiologist and an anesthesiologist assistant? What are each of them?
Okay, cool. Yeah, cool. So it's about the way that you get there. So each one of those providers, anesthesiologist assistant, physician anesthesiologist, and a nurse anesthesiologist or CRNA, those are the three types of anesthesia providers that we have in the United States. If you go to England, only physicians provide anesthesia. They call them anesthetists, or more specifically, anesthetists. So here in the States, we have three types of anesthesia providers. Anesthesiologist assistants are kind of like physician assistants, PAs. So they have a master's degree in anesthesia. They have to have a bachelor's degree in something. It doesn't have to be nursing or anything healthcare related. And so you just go get a master's in anesthesia. Like a lot of PAs, physician assistants, you don't have to have a bachelor's in anything healthcare related. You take a master's course in kind of healthcare type classes. And then anesthesiologist assistants have to work directly under a physician anesthesiologist. They have to be supervised. Physician anesthesiologists and CRNAs are trained in the same way in terms of the provision of anesthesia. Physician anesthesiologist obviously goes to medical school first, and then they do like 3 years of anesthesia training. Nursing anesthesiologist or CRNA goes to nursing school first, and then they do that like 3 years of graduate level anesthesia training. Their function in the OR, their scope of practice, the tools, techniques, the science, all the stuff they do in the operating room, the cases they do, the complexity, that all of that is exactly the same.
What are some of the addictive chemicals or products within an anesthesia surgery?
So any of the stuff can be addictive. So people have, and what's interesting is that drug diversion, addiction, mental health, and suicide is actually a problem with healthcare providers. Like we're not all like dialed in on top of our lives. So, for instance, I had a girl reach out to me. I did a podcast a couple of years ago on hardship in anesthesia school, like how hard graduate school can be. When I went through school, a girl in my program committed suicide with medications that she diverted from the clinical site. She had a bad breakup with a boyfriend. No one knew this was going to happen. So I did a podcast about that experience. And then just this summer, someone reached out to me from the University of North Carolina at Charlotte and said, hey, my roommate and classmate just committed suicide with medications that she diverted from the clinical site. Can we talk about that? So diversion, suicidal ideation, addiction, those things can be real problems for healthcare providers. To answer your question specifically, the sedative medications, things like benzodiazepines, Versed, propofol, like Michael Jackson drug, the opioids, the painkillers. It's less common. Like back in the day when anesthesia, like there was a time where there wasn't anesthesia, and then there was a time where there was. The very early types of anesthesia, we still use some of those, like nitrous oxide. And then there's been more elegant iterations of the inhalational anesthetics. People don't abuse those as much. Back in the day, they used to have nitrous oxide parties where like dentists would put this gas like in bags, in rubber band bags, and they would go to their like elite social dinners, like back in the early, like the late 1800s, and they would huff these bags of inhaled anesthetics. That's way less common now, but those can be abused as well.
What would you say is the biggest concern with anesthesia?
The biggest concern with anesthesia?
Yeah.
Well, I don't know how to take that question. Like more, so I guess just from a global perspective, like the biggest concern when providing anesthesia is patient safety, right? I know there was a question there somewhere like how safe is anesthesia? Anesthesia is super safe. Surgery, interestingly, in the United States is really safe. We often tell patients that getting, like having a surgery, like the most risky thing about having a surgery is often driving to the hospital to have your surgery. So like driving your car is still super dangerous in the United States. We take our jobs incredibly seriously, and we have an array of processes that we implement to keep patients safe. And vigilance is really a huge thing for us. So that's why I said, like, we're there, like we're literally monitoring every breath, every heartbeat. We keep your autonomic nervous system. There's a question about that. Totally in check. Like even though you're asleep, your body still senses pain when surgeons cut, like with a knife. So we manage all of those things as anesthesia providers to keep homeostasis, flying smooth during a surgical case. So we are like, patient safety is, if there's like a mantra, like literally the mantra of the American Society of Anesthesiologists is vigilance, because safety is such a core thing of what we do.
This is a longer question, but it's like you'll see. This student had shoulder surgery, and they put a nerve block into her neck, and she wanted to know if it was common and what would happen without the block.
Oh, that's great. Such a great question. I'm so glad you got a block. It's super common. It's the best practice. It's top notch. And what's really fascinating about that, we talked a lot about like opioids and addiction and inhalational anesthetics. A whole thing I haven't mentioned is regional anesthesia. You have nerves that go from your spinal cord all throughout your body. And if you're having like an extremity surgery, like a shoulder surgery or an arm or a leg or lower abdominal surgeries, one of my most fun environments to work in is obstetrics with women who are having babies. So doing epidural anesthesia or spinal anesthesia. So all of these things are going in with needles and targeting specific nerve groups and giving a local anesthetic that blocks the nerve function from happening, but it only happens to that local nerve group. So you literally become numb. Your brachial plexus is a nerve bundle that comes off of your cervical spine into your shoulder, controls all of the motor and sensory function of your arm. You put 20 cc's, like a little syringe of local anesthesia in the neck, you're completely numb. sometimes up for 3 days after your surgery, and you could stay completely awake for that surgery. Oftentimes for shoulder surgeries, we still get you off to sleep, because most patients, they don't want to hear like bone saws and, you know, hammering and grind, you know, you don't like, it's like a construction zone in the OR. It really is. It's like an auto body shop for your car, except everything's sterile and we're working on you and not your car. But it's a construction zone. And so that nerve block, if you didn't have that, you would be in a lot more pain. By getting a nerve block, we're able to avoid things like opioids, general anesthesia, systemically acting anesthetics that work on the brain. If you can block a nerve group, you don't have to put the brain to sleep. We often give you a little sedation to make it more a comfortable experience, but we don't have to.
When you do those long surgeries, are you allowed to take breaks during that?
Yeah. I mean, someone is always with you. So if I do a 10-hour case, I get a 15-minute break in the morning. Another CRNA comes in. I give them a handoff so they know everything that's going on with the patient. I step out. I go to the bathroom. I get a snack, get a cup of coffee. Same thing for lunch, afternoon break. A big thing, because we're humans doing this work that's super important. You don't want those humans doing that work to get fatigued. Surgeons take breaks sometimes. They take quick breaks to come back, because we also don't want patients in the operating room like with nothing going on with them, right? So all healthcare providers take breaks because that's important for the patient safety, really.
Do you see non-opioid anesthesia as something that will take over?
I think there's a place for opioids. Opioids are considered, they're super effective at pain control, but they're not great in terms of the immune response for the body. So opioids are actually implicated in the development of chronic pain syndromes. So anytime you have surgery, you can develop pain. Opioids, they prevent your experience of pain acutely, but they actually facilitate development of chronic pain syndromes. So while they can be effective in small doses for a really short amount of time, so like the pain of surgery, your body as it heals, the pain of surgery actually wanes after like 2 days, like 24 to 48 hours. Like while your surgery is happening, super painful, right? You don't want to get cut on and cautery, like literally burning of little blood vessels. Super high stimulation, high pain if you were awake for that. That's how surgery used to be. A good surgeon in the Civil War was considered someone who was fast at cutting your leg off because they had no anesthesia. So if you could cut a leg off and sew off all the blood vessels quickly, you were considered a good surgeon. Then they thought of anesthesia, became up with anesthesia. The world, like surgery changed. It's a modern day miracle. But yeah, I think that someday we're going to continue to move away from opioids because we have better medications. And the world is also waiting on folks like you to go out there and create new medications. We're not done creating things in healthcare. Like we haven't figured it out. Anesthesia really has only been around for like 100, 150 years. In many ways, we're just getting started with this science, with this technology, with this pharmacology. We need more people to engage. It will not get done unless people engage with the process to make the system better.
Couple more questions on the same topic. Would non-opioid anesthesia be helpful for people that are recovering addicts?
So that's an interesting question. There is no problem getting opioids if you are a recovering addict in the acute phase. Sorry, I'm just pulling this out so I can see the time. So I take care of active addicts. I take care of people who are actively using, who are actively intoxicated, who are actively overdosing on medications. I take care of recovering addicts. I take care of the whole spectrum of humanity that comes to the hospital. Opioids are okay for recovering addicts in a very short time frame, but some people psychologically, they just don't want those substances in their body. We often don't give them to patients in a way that they would have a sensation of that. It's one, the dosing is very different than if you were shooting up for pleasure or as part of your addiction. We also, a lot of times we're gonna get the patient asleep with medications that turn their brain off, before they get those opioid medications. So they're not getting that euphoric high of shooting up with opioids. So we give them in a way that's very safe, but some people still say, I just don't want those in my body at all. And we can accommodate that.
The next two questions are about states. So do specific states, is the anesthesia process different from state to state? Like you practice in Maine, would it be different in California, Colorado, Wyoming?
Yeah. The practice of anesthesia state by state is the same throughout the United States. So the technology and stuff out there is the same. You do see a difference. I mean, there's a difference between, having a surgery done in a super small rural setting and having a surgery done in a big major medical center. More challenging, more complex cases, more rare things are going to happen at major medical centers that, because of their volume, they see those more often. But the actual delivery of anesthesia, everyone's got the same tools across the United States. I mean, I would say like in some really small places, just because of their volume and income, they might be dealing with like older equipment in their operating rooms, but you should get the same level of safety no matter where you go. And the anesthesia provider is a really important element of that. So it kind of depends on that particular center in terms of what they're really good at. Some really, and I don't mean to make a small one. Some don't do the big cases, but they're really good at doing the simple cases like colonoscopies and niche and like labor and delivery. Like they're really good at that. Quality monitoring and quality assurance is something that you can find out. It's publicly available information that you can find out about particular hospitals in terms of, what's their accreditation status, how good are their outcomes. You can find that information out.
And then do specific state allow opioid use when it comes to surgeries? Is that
no?
Okay.
No, it is not outlawed.
Is it true that people with naturally red hair require more anesthesia?
Yes, it is true, and they don't know why. But we know that. Like we know about you. We know about you in healthcare. We gear up a little bit more. So they take on average like 20 to 30% more anesthesia to get off to sleep. Young people, it's very well known that like babies take, like dose dependent, babies take a lot of anesthesia, and then it actually shrinks to infants, like kids that are about a year old. And then anesthesia need increases till you're about like 20 or so. Like y'all, like undergraduate college students, I got my eye on you. Big muscular males, little bitty skinny redheaded girls. I got my eye on you when you come to the OR. Like I know you're going to require more anesthesia, and then it wanes. Your requirements wane throughout the lifespan. So like really old people, they require just like a whiff, and that's part of the art of anesthesia, right? Like you learn these things about people. It's not just a science, but there's an art form to it as well.
How do the different kinds of anesthesias actually work? And is one type better than another or more effective than another?
Yeah, that's great. So your body has receptors throughout your body. We talked a little bit about, so anesthesia is concerned about like your brain. So sedation levels, whether your brain is on or off. So there's centrally acting receptors in your brain. So GABA receptors that some of the medications potentiate those things. So they're naturally occurring like sedative processes that work in like your normal sleep-wake cycles. You just kind of like ramp those with pharmacology. So we can turn your brain off from a central standpoint so you're not aware of what's going on. And then we can also tinker with like your spinal cord and the actual innervation in the pathways of neurosignals along your nerve roots. And so we can turn those things off with anesthesia medications. So we either give stuff like IV that goes centrally acting that works in your brain, or like we talked about, regional anesthesia with needles to go in and just block a specific nerve group. There's also like topical anesthetics. You can put like cream on your skin before you get an IV that numbs up your skin. But in the most basic ways, we think about centrally acting intravenous or IV anesthesia, or regionally acting anesthesia that we administer through nerves. And it has to do with the specific receptors throughout the body. There's a lot of receptors. So GABA receptors, NMDA receptors, cyclooxygenase receptors, pain receptors, mood receptors, opioid receptors, cannabinoid receptors. There's all different kinds of receptors in the body. We learn how to tinker and manipulate all of those things. It's like being a chef in a really nice restaurant. You learn about all the different flavors and all the different things that make something work out really well. You pick out a soup, you pick out a combination of medications to get someone through the room safely. We give those things, we turn off the anesthesia, and we wake you up right on time.
I'm going to bounce around through the chat now just because we have 5 minutes left. How does your work intersect with insurance companies? Have you seen a change in your work since the Affordable Care Act was passed?
Yeah, the Affordable Care Act has been a massive change. So in my work as a CRNA, I have zero involvement in the billing that goes on. So my typical day, someone asked like, how many years did it take me to do this? I mean, talking about 4 years of undergrad. I spent 5 years in an ICU, but it takes 1 to 3 for that critical care experience. I'm not counting my undergrad in outdoor ed, and then a 3-year master's program. So for me, my total training from like when I decided to go to anesthesia school and when I was done was about 9 years. You can shorten that up substantially. I mean, you only need 1 year of critical care experience. I did 5, so you could get through in, 5 or 6 years from like start to finish. But what all of that training does is it enables me, like I walk in the door, I change out of my street, I commute on my bicycle to work, I lock my bike up, I go inside, change out of my street clothes, put on scrubs, put on a hat and a mask, go into the OR, set up my OR, check it off, go meet my patient, make sure they're queued up for surgery, take them into surgery, put them to sleep, wake them up, do that process anywhere from 1 to 12 times a day, depending on the case types. And at the end of the day, I peace out, I go home, and I don't think about it. And magically, every 2 weeks, I get a paycheck. So we have a team of people that process insurance claims and billing and all that kind of stuff, and they handle that. I know about those things. I could talk more about that specifically. The Affordable Care Act has enabled people to get surgeries that they otherwise wouldn't have access to. So it has eliminated the pre-existing condition clause. So people are able to get cancer surgery is a massive thing of what we do. And they're able to get those surgeries because they can afford it. Healthcare is still dramatically broken in the United States. It's way too expensive. But the Affordable Care Act has been a really, really important step in that process. And in my personal opinion, it's a step that we need to protect and actually take further. I think having some sort of single payer universal healthcare system, just from a social justice standpoint and from a society-wide public health standpoint, would be a really, really important step. The influence of profits in healthcare is far too strong. And that's profits primarily from insurance companies and pharmaceutical companies. And then like after that would come like for-profit healthcare systems. But pharmaceutical companies and insurance companies are the major profiteers in healthcare. And that system needs to change. But it won't change as long as healthcare remains privatized. It has to shift to like some sort of at least a government regulated, if not government run model.
Sweet. I'm going to do 2 more questions. One, I'm going to combine. We have one student who's just pursuing a graduate degree in healthcare, and the other student is looking for an accelerated nursing program. And they wanted to know, do you have any advice for them, either accelerated nursing or degree in healthcare?
Yeah, for sure. I would say go for it. It is never too late. I had an undergrad in outdoor ed. I was an outdoor guide for a bit, started off in EMT land. And then my undergrad in nursing was actually an accelerated nursing program at St. Louis University. So it helped me get a bachelor's degree in a condensed amount of time. to get into the ICU working as a critical care nurse. If you're in graduate school for health sciences, I mean, healthcare is really fascinating. I would say simply, since I know you have another question, shadow people, call a healthcare provider, get in there, see what's up. It might seem like boring and uninteresting and nerdy. And I know hospitals smell weird. They smell like old people and like weirdness, but it is a fascinating world to work in, and you can bring all of your creative energy and passion. It's a space for adrenaline junkies. It's a space for nerds. It's a space for people who want to make a difference.
Okay, the last question. Do you have a certain surgery you enjoy working on more than others?
I do. Trauma surgery, hands down. I absolutely love when people are beat up from the feet up and their life hangs in the balance. There's nothing more enthralling for me to have someone come in and knowing that the actions that I take and that my team takes in that moment will determine whether or not they live or die. And those often are the stakes that we have with our patients. And it goes all the way from teaching wilderness medicine with Knowles, from taking someone who, has an accident in a remote setting, all the way through the pre-hospital EMS system. We are that definitive care level in the operating room, and knowing that, I mean, those surgeries are not normal. Like, just Google image trauma surgery and you'll know what I'm talking about. You're often going to see pictures of like blood splattered rooms in, frankly, excuse my French, but like shit all over the place. And like, it's like a war zone, and being able to be functional in there, being able to be calm, to like crack that can of calm and just be chill and bring a level of expertise and professionalism. Y'all, it's the best. It's so much fun. And then you get to go chill. Like, you make a really good income. You have a great job, and you get to go take van trips in East Burke. What? And do cool stuff like this. Talk to NVU. Thank you so much for this opportunity, y'all.
We are out of time, so thank you very much.
Cool, thanks. I know there's a hard stop. Check out the podcast. Shoot me an email. I'd love to chat with you more.
Great.
Thank you so much. That was great. We really appreciate it.
All right, Emily, keep saving the world.
We'll see everybody next week.